In February 2025, a 65-year-old woman named Betsy Arakawa died alone in her Santa Fe, New Mexico home. She was a classical pianist. She was the wife of actor Gene Hackman. She had no warning that what she was experiencing was anything more than a flu. She made an appointment with her doctor on the 12th of February. She never showed up. She was dead before she could get there. The cause was Hantavirus Pulmonary syndrome, a disease most Americans had never heard of. A disease with no cure, no vaccine, and a fatality rate that the CDC estimates at approximately 38% for patients who develop its most severe respiratory form. She was not an outlier. She was not in an unusual situation. She was a person living in a region of the United States where this virus has been circulating for decades, and she didn't know the signs. This video is a complete clinical explanation of Hantavirus Pulmonary syndrome. What it is, how it develops, what it does to the human body, and what prevention actually looks like in practice. My name is Dr. Jonathan Lee. I'm a physician and virologist with specialization in infectious diseases, epidemiology, and emerging pathogens. I've spent 20 years studying the relationship between zoonotic viruses and human disease outcomes. And hantavirus is one of the most underestimated pathogens in public health. Not because it has the reach of influenza, but because in the people it does infect, it is extraordinarily lethal, extraordinarily fast, and extraordinarily preventable with the right information. Let me start with the history, because it explains why this disease remained invisible for so long. In the spring of 1993, an outbreak of severe respiratory illness struck the Four Corners region of the American Southwest, the area where Arizona, Colorado, New Mexico, and Utah meet. Young, previously healthy adults were developing a mysterious illness that looked like influenza in its early stages and progressed to fatal respiratory failure within days. The initial fatality rate was approximately 50%. Investigators were alarmed. Nothing in the existing disease literature matched what they were seeing. The CDC dispatched a team. Within weeks, they identified the cause, a previously unknown hantavirus, later named Sin Nombre virus, which translates from Spanish as nameless virus, carried primarily by the deer mouse. That outbreak killed half the people it infected and launched 3 decades of federal surveillance. Since 1993, when surveillance began, a total of 890 laboratory-confirmed cases of hantavirus have been reported in the United States through 2023. Of those, 94% occurred west of the Mississippi River. The Four Corners states, New Mexico, Colorado, Arizona, and Utah carry the highest burden, but cases have been confirmed in 40 states. In 2024 alone, the United States reported 20 confirmed cases and 8 deaths, a 40% case fatality rate in that year's cohort. And in December 2025, the Pan American Health Organization issued a critical epidemiological alert. 229 confirmed cases of hantavirus cardiopulmonary syndrome and 59 deaths had been reported across the Americas that year, concentrated in Argentina, Chile, Paraguay, and Brazil. This disease is not going away. It is an endemic presence in rodent populations across the Western Hemisphere. And in May 2026, it made global headlines again when an outbreak of Andes virus, the South American strain, spread through passengers aboard the cruise ship MV Hondias, resulting in 8 cases and 3 deaths across 7 countries, prompting the CDC to issue Health Alert Network Advisory HAN 0528 and the WHO to declare a multi-country disease event. Now let's get into the science of what this disease actually is and what it does. Hantaviruses belong to the family Hantaviridae. They are RNA viruses, which means their genetic material is ribonucleic acid, less stable than DNA, prone to mutation, and historically difficult to target with antiviral drugs. They are zoonotic, meaning their natural reservoir is an animal, in this case, specific species of rodents, and humans are incidental hosts. The virus does not need us. We are a biological dead end for it. And yet, when it reaches us, the consequences can be fatal. In the Americas, hantavirus causes what is called Hantavirus Pulmonary syndrome, abbreviated as HPS, or sometimes Hantavirus Cardiopulmonary syndrome, HCPS, because the disease affects both the lungs and the heart. The two terms refer to the same clinical syndrome. The primary strain in North America is Sin Nombre virus, carried by the deer mouse Peromyscus sonoriensis and related species. In South America, Andes virus is the dominant strain and the only hantavirus in the world known to transmit from person to person, a characteristic that no other hantavirus shares. Transmission to humans happens almost entirely through inhalation. When infected rodents shed the virus in their urine, droppings, and saliva, those materials dry and break down in the environment. The resulting microscopic particles become airborne. A person breathing in a contaminated enclosed space, a cabin, a garage, an attic, a storage shed, can inhale those particles directly into the respiratory tract. The house mouse and Norway rat, most frequently encountered in urban homes, are not carriers of hantavirus strains that cause HPS. The risk animals are field species: the deer mouse, the white-footed mouse, the cotton rat, the rice rat. These are animals that frequently enter rural homes, outbuildings, vacation properties, and structures at the edge of natural habitat. Now, let me take you through the 3 clinical phases of hantavirus pulmonary syndrome, because understanding this progression is the most important clinical knowledge a layperson can have. Phase 1 is the incubation period. This runs from 1 to 8 weeks after exposure. The average is 2 to 3 weeks. During this entire period, the person feels entirely well. The virus is replicating silently, establishing itself in the endothelial cells, the cells lining the blood vessel walls. But the patient has no awareness of it and no symptoms. Phase 2 is the prodromal phase. This is the phase where the disease becomes visible and where it is most commonly misdiagnosed. The prodromal phase typically lasts 3 to 5 days. Its symptoms are fever, almost always above 38 degrees Celsius, deep muscle aches, myalgia, with a characteristic distribution in the thighs, hips, and lower back that patients describe as severe and unusual compared to ordinary body aches. Intense headache, chills, profound fatigue, and in approximately half of all HPS patients, gastrointestinal symptoms, nausea, vomiting, diarrhea, and abdominal pain. That cluster of symptoms, fever, muscle aches, fatigue, gastrointestinal distress, is diagnosed as influenza or viral gastroenteritis many thousands of times every day in clinics and emergency rooms across the country. There is nothing in that symptom list that says hantavirus to a clinician who is not specifically thinking about it. Which is why the single most important fact in this entire video is this: the clinical differentiator is not the symptoms, it is the history. Specifically, rodent exposure in the preceding 1 to 8 weeks. If you or someone you know has those prodromal symptoms and has had any contact with spaces where rodents live or have been, a cabin opened after winter, a garage with evidence of mouse activity, outdoor work in a rodent habitat, travel to an endemic region in South America, that exposure history must be communicated to a physician immediately. It is the piece of information that transforms the diagnostic calculus entirely. Also, during the prodromal phase, the blood shows characteristic findings that are not present in influenza: thrombocytopenia, a falling platelet count, hemoconcentration, a rising hematocrit as fluid begins leaking from blood vessels, a left shift in the white cell count, indicating the body is producing immature immune cells rapidly, and on a blood film, large activated lymphocytes called immunoblasts. These findings, in a patient with the right exposure history, are a near diagnostic signal for hantavirus. Phase 3 is the cardiopulmonary phase. And this is where HPS becomes a medical emergency. The transition from the prodromal phase to the cardiopulmonary phase can occur with alarming speed. Patients who are stable, uncomfortable but ambulatory, can deteriorate into critical illness within hours. This rapid deterioration is one of the most distinctive and dangerous features of the disease. What is happening biologically is this: the virus has been multiplying inside the endothelial cells of the blood vessels. The immune system, recognizing the infection, mounts an aggressive inflammatory response. That response, the release of inflammatory cytokines, causes the walls of the blood vessels to become abnormally permeable. They leak. In the lungs, this means fluid moves from the bloodstream into the air sacs, the alveoli, where oxygen exchange occurs. The lungs fill with fluid. This is called non-cardiogenic pulmonary edema, lung flooding caused not by heart failure, but by leaking blood vessels. The patient cannot take in adequate oxygen. Breathing becomes labored, then desperate. Simultaneously, blood pressure drops as the circulating fluid volume falls. The heart is stressed. In severe cases, the virus triggers direct myocardial depression, suppression of the heart muscle's ability to contract effectively. This can produce dangerous cardiac arrhythmias. 75% of patients who enter this phase require mechanical ventilation. Most deteriorate within 24 hours of its onset. Without intervention, the majority of deaths from HPS occur within 24 to 48 hours of this phase beginning. The treatment is entirely supportive. There is no approved antiviral drug for hantavirus pulmonary syndrome. Ribavirin, which has been used against other RNA viruses, was studied in clinical trials for HPS and did not demonstrate a meaningful survival benefit. Management consists of oxygen supplementation, careful fluid management, mechanical ventilation, and hemodynamic support. In the most severe cases, the treatment that offers the best survival outcomes is ECMO, extracorporeal membrane oxygenation. ECMO takes blood from the patient's body, removes carbon dioxide, oxygenates it, and returns it, bypassing the failing lungs entirely, giving them time to recover. For patients who receive ECMO at the earliest sign of decompensation, the survival rate is approximately 80%. That outcome is remarkable given the baseline fatality rate of the disease. But ECMO is only available at specialized tertiary care centers. It requires immediate access and a clinical team trained in its use. A patient who arrives at a small rural hospital without these capabilities, or who arrives too late, faces a much narrower window. This is the central argument for early presentation. Getting to the right facility before the cardiopulmonary phase fully establishes itself is the most important determinant of survival, not treatment, because treatment options are limited. Now the fourth phase, the diuretic phase, marks the beginning of recovery in patients who survive the cardiopulmonary crisis. The kidneys begin expelling the excess fluid. Blood pressure stabilizes. Lung function begins to recover. This phase can begin within 24 to 72 hours of the cardiopulmonary peak in patients who receive adequate supportive care. But recovery from HPS does not end there. And this is a part of the disease story that rarely gets told. A 5-year follow-up study of HPS survivors by researchers at the University of New Mexico found that at 5 years post-infection, mild to moderate pulmonary abnormalities were common even in people who had recovered. 79% showed decreased small airway flow. 76% had increased residual lung volume. 66% had decreased oxygen diffusion capacity. 84% reported ongoing myalgias and shortness of breath. 55% reported problems with short-term memory and joint pain. A 2025 multi-center study in Chile of Andes virus survivors found that 61.9% reported incomplete recovery at 3 to 6 months post-symptom onset. Nearly 1 in 5 had not returned to work or school 6 months after infection. For those who did return, recovery took an average of 3.5 months. 45% of ECMO patients reported stigma at work or school related to fear of their illness. HPS does not end at hospital discharge. The burden of this disease extends far beyond the acute phase for many survivors, sometimes for years. Now let me turn to risk, because one of the most common questions I receive about hantavirus is, should I personally be concerned? The answer is always contextual. So let me give you the framework. The general population risk is low. In absolute numbers, fewer than 50 cases are confirmed in the United States in most years. For the average urban resident with no exposure to rural environments or rodent-infested spaces, the probability of encountering hantavirus in any given year is extremely small. But the risk is not zero, and it becomes meaningfully elevated in specific circumstances. Geographically, the highest risk zones in the United States are the western states, particularly New Mexico, Colorado, California, Texas, Washington, and Montana. These states account for the majority of historical HPS cases, driven by deer-mouse population density and habitat. Occupationally, agricultural workers, forestry workers, pest control professionals, construction workers in older or rural buildings, and park rangers or field researchers with regular exposure to rodent environments carry elevated risk. Recreationally, the risk is highest for people who camp in rodent-endemic areas, use cabins or rural properties that have been closed during winter, hike in the American Southwest, or travel to rural areas in South America, particularly Argentina, Chile, Bolivia, and Paraguay. At home, the risk is concentrated in specific activities: cleaning enclosed spaces where mice have been active, handling stored materials from basements, attics, or garages with rodent evidence, or moving into older rural properties. One of the clearest case studies of recreational exposure was the 2012 outbreak at Yosemite National Park. 11 people who stayed in specific tent cabin units contracted hantavirus. 3 died. The source was identified as infected deer mice nesting in the insulation of the cabin walls. The infection happened during sleep. The victims had no idea there was any risk. And in 2024, a cluster of 3 fatal HPS cases in Mono County, California, including a 26-year-old hotel employee, again demonstrated that the disease can strike ordinary settings and ordinary people. Betsy Arakawa, a 65-year-old living in a gated residential community in Santa Fe, had no unusual risk factors. She was simply living in a region where the virus is endemic, where infected deer mice are part of the local ecosystem, and where the probability of a mouse entering a home structure is real. That is the nature of endemic disease. It doesn't need a dramatic exposure. It needs proximity and time. Prevention is the only reliable intervention. Let me be clear and specific. The 3 pillars of prevention are seal, trap, and clean, in that order. Seal means making your living and working spaces rodent-proof. Mice can enter through gaps as small as 1/4 of an inch, the width of a pencil. Inspect all exterior walls, foundation gaps, pipe entry points, window frames, garage door seals, and utility line entry points. Use steel wool, hardware cloth, caulk, or metal flashing to close every identified gap. This is not a one-time activity. It is an annual inspection practice for anyone living in or near rodent-endemic areas. Trap means managing any existing rodent population around your home. Use snap traps, not glue traps, not live traps, which keep the animal alive and producing infectious material. Place traps along walls and behind appliances. Check daily. Handle carcasses with rubber gloves and dispose in sealed bags. Clean means never using dry methods, sweeping, vacuuming, or blowing in any space with rodent evidence. This is the most critical and most commonly violated rule. Dry cleaning aerosolizes the viral particles that cause infection. The correct protocol: ventilate the space for 30 minutes before entering. Wear rubber gloves and an N95 respirator for spaces with significant contamination. Saturate all contaminated surfaces with a disinfection solution of 1 part bleach to 10 parts water. Let soak for 5 minutes. Wipe with disposable cloths. Seal everything in plastic bags. For heavily infested spaces, attics, barns, abandoned properties, retain a licensed pest control professional. The accumulated viral load in such environments can be dangerous beyond what personal protective equipment is designed to manage safely. When should you go to the emergency room? Go now. Do not call first. Do not wait for a regular appointment. If you have had any potential rodent exposure in the past 8 weeks and you develop any of the following: fever above 38 degrees Celsius or 101 Fahrenheit, severe muscle aches, particularly in the thighs and lower back, and any new shortness of breath, chest tightness, or cough developing after a flu-like illness. At the emergency room, say these exact words to the triage nurse: I have had potential rodent exposure, and I am concerned about hantavirus. Request that a complete blood count be drawn and hantavirus serology ordered. Hantavirus testing requires either ELISA antibody testing detecting IgM and IgG, or RT-PCR to detect viral RNA. Neither is part of a standard fever workup. Both must be specifically requested. Early diagnosis before the cardiopulmonary phase is the only intervention that meaningfully changes outcomes. There is no last-minute rescue in HPS. The window between warning and crisis is measured in hours, not days. I want to close by placing this disease in its proper context. Hantavirus pulmonary syndrome is not a disease that threatens to become a pandemic. It does not spread easily between people. It requires a specific animal contact and a specific exposure route. By the numbers, it is rare. But rare does not mean unimportant. It does not mean impossible. And for the people it reaches, the hiker who cleaned a dusty cabin, the homeowner who swept the garage, the person who simply lived in the wrong county at the wrong season, it moves with a speed and severity that leaves very little room for error. Betsy Arakawa called her doctor on the 12th of February 2025. She didn't make it to the appointment. That 8-week incubation period had run its course. The cardiopulmonary phase had begun, and she was gone within hours. She did not have to be a statistic, and neither do you. That is why I made this video. Subscribe to Outbreak Intelligence for this level of clinical depth on every emerging pathogen that matters. I publish on the viruses that public health systems are watching, and that mainstream coverage routinely oversimplifies. If that is the standard you want from your health information, subscribe. I'm Dr. Jonathan Lee. Know this disease. Share this video. It could matter to someone you know.